of liver L16 lipids. Clinical overview of liver failure. Cirrhosis is the most prevalent form of chronic liver disease and liver failure in the United Kingdom. The underlying causes vary and include metabolic and toxic insults such as alcohol use and metabolic syndrome-related fatty liver disease, infections like viral hepatitis and schistosomiasis, autoimmune and biliary conditions, e.g., autoimmune hepatitis, primary biliary cholangitis, and genetic disorders such as hemochromatosis and Wilson's disease. Globally, viral hepatitis has historically been the leading cause, although metabolic syndrome is becoming increasingly common. In the UK, alcohol and metabolic syndrome are the dominant contributors, while other causes are relatively rare outside of transplant centers. Cirrhosis progresses gradually through sustained inflammation, which results in fibrotic scarring. Over time, this compromises liver structure and function. Many individuals remain asymptomatic until advanced liver failure develops. Key clinical signs of liver failure include jaundice, coagulopathy, and hepatic encephalopathy. Despite the liver's remarkable regenerative capacity, outcomes in advanced liver disease remain poor, with rising mortality rates. Types of liver failure syndromes. Two primary liver failure syndromes are recognized: acute liver failure, ALF, and acute on chronic liver failure, ACLF. Alcoholic hepatitis shares features of both but occupies an intermediate clinical space. Acute liver failure, ALF, is an uncommon but severe condition characterized by sudden liver dysfunction, including encephalopathy, occurring within 8 weeks of symptom onset in individuals without prior liver disease. Common signs include jaundice, coagulopathy, and multi-organ involvement. In the UK, the most frequent cause is paracetamol overdose, whereas globally, viral hepatitis is a leading cause. Other triggers include certain medications, toxins, ischemia, and metabolic disorders. The underlying mechanism of acute liver failure, ALF, involves a sudden injury to the liver that triggers extensive cell death through necrosis or increased apoptosis. When the damage surpasses the liver's capacity to regenerate, it can lead either to full organ failure or, in some cases, eventual recovery. ALF is further categorized based on the interval between the onset of jaundice and the development of encephalopathy. In hyperacute cases, where symptoms progress in less than 7 days, commonly seen with paracetamol toxicity, patients are typically younger and at risk of developing increased intracranial pressure. The acute subtype, with a time frame of 8 to 28 days, is the most frequently encountered globally and is often linked to hepatitis B. Subacute ALF, which develops over 5 to 12 weeks, is more prevalent in older adults and often results from drug reactions or occurs without a clearly identifiable cause, seronegative. The specific cause of ALF plays a critical role in determining the severity of complications, the likelihood of recovery, and the potential need for liver transplantation. Acute on chronic liver failure, ACLF, is a common condition and develops in individuals with existing liver disease, typically cirrhosis, who experience a sudden clinical deterioration accompanied by failure in other organ systems. This syndrome has a high mortality rate and often resembles ALF in its presentation. Unlike ALF, emergency transplantation is rare. Alcoholic hepatitis is also common and represents an acute hepatic insult in patients with a history of significant alcohol misuse. It typically occurs against a background of fatty liver disease and is marked by jaundice, with or without encephalopathy. Cirrhosis is not a prerequisite, but liver injury is often advanced. Transplant eligibility for these patients is restricted in the UK due to the requirement for sustained alcohol abstinence. Across all forms ALF, ACLF, and alcoholic hepatitis, there is a considerable risk of death, multi-organ dysfunction, and infection. Immune dysfunction in liver failure. Immune dysregulation plays a central role in the progression and poor outcomes of liver failure syndromes. Understanding and targeting the mechanisms behind immune dysfunction could help improve survival and reduce reliance on transplantation. The innate immune system, particularly monocytes, macrophages, and neutrophils, is primarily involved. In ACLF, Systemic inflammation is reflected in elevated leukocyte counts and C-reactive protein levels. Circulating pro-inflammatory cytokines such as Illinois 1 beta, Illinois 6, Illinois 8, and TNF are elevated, while anti-inflammatory cytokines like Illinois 10 are suppressed, indicating a pro-inflammatory immune environment. Monocytes and macrophages exhibit altered function. These cells are activated by molecular patterns associated with tissue damage or infection. They are activated by PAMPs, pathogen-associated molecular patterns, and DAMPs, damage-associated molecular patterns, from damaged liver or gut pathogens. Initially, they adopt a pro-inflammatory state characterized by cytokine production and bacterial clearance. Normally, these cells would then reprogram to a repair phenotype, stop producing TNF-alpha and Illinois 6, start producing Illinois 10, express Merck and CD163, and HLA-DR becomes low. This repair signal also occurs in liver-resident macrophages, Kupffer cells. Neutrophils also show abnormal behavior. In ACLF and alcoholic hepatitis, these cells exhibit increased degranulation and oxidative stress but reduced capacity to clear bacteria. A rise in CD177+ neutrophils indicates excessive degranulation, which can damage tissues and contribute to organ failure. The role of metabolomics in liver disease. Metabolomics, also referred to as metabonomics, involves the comprehensive analysis of small molecule metabolites within biological systems and represents the final layer of the central dogma of biology, following DNA, RNA, and protein expression. This field is particularly relevant in liver disease, given the liver's central role in metabolic regulation. Liver failure disrupts numerous metabolic pathways, making metabolomic profiling a valuable tool for understanding disease mechanisms. By simultaneously measuring thousands of metabolites, researchers can assess how the body responds to pathological conditions. Advanced statistical techniques, such as principal components analysis, PCA, are often used to interpret these large datasets, allowing for the classification of patient groups, such as survivors and non-survivors, based on their metabolic signatures. Analytical methods like proton nuclear magnetic resonance, to the power of 1 HNMR, spectroscopy and ultra-performance liquid chromatography mass spectrometry, UPLCMS, are commonly employed, with mass spectrometry now more widely used. Metabolomics can be conducted using either targeted approaches, focusing on known metabolites, or untargeted methods that detect a broad array of compounds for later identification. These analyses can yield quantitative data or relative concentration profiles. In the context of liver failure, metabolomics has been utilized to predict clinical outcomes. Research has identified key metabolic markers, including specific amino acids, pyruvate, lactate, isobutyrate, and lipids, that differ between patients with favorable and poor prognoses. For example, NMR-based studies in individuals with acute decompensated cirrhosis and organ failure have revealed distinctive metabolic patterns, with a particular lipid-associated signal significantly reduced in patients who did not survive. Lipid dysregulation and immune interaction in liver failure. Lipids are a diverse group of predominantly hydrophobic, non-polar molecules that are largely insoluble in water, although some, such as phospholipids, contain polar regions like head groups that contribute to their structural and functional diversity. Key lipid subclasses include triglycerides, steroids, such as cholesterol, and phospholipids, with the latter playing a critical role in cellular membranes. One important subclass of phospholipids is lysophosphatidylcholines, LPCs, which are enzymatically converted into lysophosphatidic acid, LPA, by the enzyme autotaxin, ATX. LPA interacts with specific receptors on various cell types, including immune cells, influencing their function. Inhibiting ATX can prevent the conversion of LPC into LPA, thereby offering a potential therapeutic strategy. Recent research has explored how the LPC-ATX-LPA signaling axis is disrupted in liver failure. Observational studies involving patients with acute liver failure, ALF, decompensated cirrhosis, and sepsis have shown that LPC levels in the blood are reduced in ALF and correlate with higher mortality. At the same time, both ATX and LPA levels are elevated in these patients. Increased expression of ATX in liver tissue, particularly through the upregulation of its gene, ENPP2, in hepatocytes during alcoholic liver disease and hepatitis B-related ALF, indicates that the liver itself regulates this pathway. Functionally, LPA affects monocyte behavior, promoting a pro-inflammatory phenotype marked by changes in markers such as CD163 and MERTK, while impairing their ability to perform phagocytosis. Experimental studies have demonstrated that LPA exposure in vitro enhances the production of inflammatory cytokines like TNF and Illinois-6 but simultaneously diminishes the monocyte's capacity to engulf bacteria such as E. coli. This dual effect makes LPA a detrimental factor in liver failure, contributing to excessive inflammation while weakening host defense mechanisms. In both ALF and acute on chronic liver failure, ACLF, this same pattern of lipid dysregulation, reduced LPC levels, increased ATX activity, and elevated LPA has been observed, along with similar immune dysfunction. These findings highlight the ATX-LPA axis as a central regulator of immune and inflammatory responses in liver failure. Given its influence on prognosis and immune function, targeting this pathway, particularly through ATX inhibition, represents a promising avenue for future therapeutic interventions aimed at restoring immune balance and improving outcomes in liver failure patients. Summary and reworded paragraph. Immune checkpoint pathways, particularly PD-L1, and TIM3, play a significant role in immune suppression observed in liver failure. Research has shown that monocytes from individuals with decompensated cirrhosis express higher levels of PD-L1 compared to those with compensated cirrhosis or healthy individuals. This expression is further elevated in patients who develop infections, and similar patterns are observed in ACLF patients with sepsis. Experimental treatment using anti-PD-L1 antibodies in mouse models of chronic liver disease with superimposed infection has been shown to reverse the immunosuppressive macrophage phenotype and reduce bacterial spread. The PD-1 receptor is also being explored as a potential therapeutic target. In acute liver failure, ALF, monocytes display increased PD-1 expression and adopt a suppressed immune profile. In vitro studies suggest that blocking PD-1 can restore the innate immune functions of these cells. Although anti-PD-1 therapies have not yet been tested in ACLF patients, elevated PD-1 levels have been noted in lymphocytes from individuals with decompensated cirrhosis and acute alcoholic hepatitis, indicating potential clinical benefit. Further investigations revealed that PD-L1 plus monocytes from ACLF patients with sepsis can induce PD-1 and TIM3 expression in healthy donor T cells when co-cultured under inflammatory conditions. TIM3 is also found in higher amounts on T cells from alcoholic hepatitis patients. Blocking both PD-1 and TIM3 in these patients' immune cells enhanced bacterial defense by increasing IFN production and decreasing Illinois-10 secretion without triggering excessive inflammation. Additionally, treating whole blood ex vivo with antibodies against PD-1 and TIM3 improved neutrophil functions, such as phagocytosis and oxidative burst, suggesting that dual checkpoint inhibition could strengthen immune responses in liver failure without provoking harmful inflammatory reactions. Research has shown that the chemokine receptors CXCR1 and CXCR2 contribute to liver cell injury in acute on chronic liver failure, ACLF, by promoting hepatocyte apoptosis, necrosis, and the release of inflammatory cytokines. This suggests that neutrophils, which express these receptors, play a role in hepatocyte damage. In vitro experiments using a CXCR1/2 antagonist, scheme 527123, have demonstrated reduced neutrophil-derived reactive oxygen species, ROS, and decreased hepatocyte cell death, highlighting the potential for therapeutic intervention. However, neutrophils are also crucial for the immune defense against infections, particularly through their ability to migrate to infection sites. In severe alcoholic hepatitis, patients show disrupted signaling in the Illinois-33 ST2 pathway, leading to reduced CXCR2 expression on neutrophils and impaired migration. This impaired signaling correlates with a higher risk of infection and short-term mortality. Treatment with Illinois 33 in vitro has been shown to partially restore CXCR2 levels and improve neutrophil migration, identifying Illinois 33 as a potential therapeutic target. These findings emphasize the importance of carefully balancing CXCR2 modulation. While inhibiting CXCR1/2 may reduce liver damage by limiting neutrophil-driven inflammation, it could also compromise the body's ability to fight infections. Therefore, any therapeutic approach targeting this pathway must weigh both the protective and harmful roles of neutrophil activity in liver disease. Addressing unmet clinical needs. Critical gaps remain in the management of liver failure. These include the need for better tools to predict which patients will require liver transplantation, improved understanding of immune dysfunction, and the development of therapies that can restore immune balance and support recovery without transplantation. In conclusion, liver failure is a complex clinical entity characterized by immune dysfunction, metabolic imbalance, and high mortality. Advances in metabolomics and lipid biology have opened new avenues for diagnosis and treatment, particularly by targeting immune metabolic pathways such as the LPCA-TXLPA axis. Addressing these emerging insights could transform outcomes for patients with ALF and ACLF.